Thank you. Okay, so I'm officially in trouble for suggesting that you should stretch, so I apologise, but I'm guessing, I was going to say, you guys haven't sat in a lecture theatre for a good few years, so it's a kind of thing. Okay, so I need to start with this slide, and this is just to say that I'm incredibly passionate about myeloma, and so I will work with any drug company who has a drug that I think might help my myeloma patients, okay? But we're always supposed to let you guys know who we potentially do work with. Your other problem is that because I'm so passionate about myeloma, those of you in the room who know me know I can talk for many, many hours, and I am what is separating you from coffee break, so I'm going to rely on Greg and everybody to tell me when I need to shut up. Okay, so this is what we're going to talk about today. I want to talk a little bit more about what we call standard risk disease and what we call high risk disease. And then we've already broached it a little bit with the first talk, but talk about how things change as we treat patients. And then finally, I want to talk a little bit more about targeted therapy and how we might be able to individualize patients' treatment. So we've heard a lot today about assessing risk. And essentially all that means is, from a doctor's perspective, is that we're trying to tell how well we think a patient's going to do with their treatment. So that could be how well they're actually going to respond to their first treatment, or indeed how long that response may last, or how long their actual overall survival may be. And one of the problems we have, which is a great problem, but really we only know about this after all of those events have happened. And so when you go onto the internet, most of the things we'll read will start off by saying myeloma is an incurable disease with a median survival of, okay? And that's because we only can look at these things retrospectively. And one of our big problems, which is a great problem to have, is that things have changed so rapidly in the last 20 years and even in the last 5 years that actually much of that data is now completely out of date. And that means that much of what we know about patients' risk is also a little bit out of date. But what we do need to do is, the way we determine this is by comparing different groups of patients together. And so we usually put patients into 3 or 4 groups. Now, I think most patients would argue that nobody having myeloma is in a good risk group, okay? I mean, but because nobody wants to be part of this club. But the way we do it is that we say patients have low risk disease, so that tends to be the kind of disease that's slow and grumbles along. We then have patients who we describe as standard risk disease, and then we've got high risk, which we've heard a little bit about today, and sometimes very high risk disease. And as Professor Holmberg said earlier, one of the problems is that every study puts different patients into different groups, okay? We can more or less decide on the extremes, as in who's very high risk and who's low risk, but there's a little bit of differences in the middle there, okay? But essentially, there's 2 kind of main things that we look at to determine risk. One is what I've called patient factors, and the other is what I've called myeloma factors, okay? So when we think about patient factors, they're very much more about how the patient is or was before the myeloma was diagnosed. So you can imagine, let's say a patient's fit and well, okay? From a doctor's perspective, that means that to some extent we don't have to worry so much about how the kidneys are going to get on with the treatment or how the heart's going to get on with the treatment. But if the patient already had 4 or 5 heart attacks and was having difficulty breathing and needed oxygen and so on, then clearly being able to deliver treatment to that patient is much more difficult. But also, if the myeloma is going to have any effects on that patient, let's say that the myeloma upsets the patient's kidneys, then that makes the whole picture much more complicated. So there's lots of things about the actual patient themselves which is important for us to think about when we're thinking about risk. There's also many things about the actual myeloma itself. Okay, so for instance, the amount of myeloma. I don't know, does anybody in the room have smouldering myeloma or MGUS? So yeah, we've got some of those patients here. Those are the patients where they have a small amount of disease and probably at the moment don't need to have some treatment, but they need close monitoring in case that amount of disease increases. But there's also patients that might have a lot of myeloma, so their bone marrow may have a lot of myeloma in it, and they might have a lot of damage from that. We're going to hear about another area which can be complicated, which is plasma cell leukemia, which is where the myeloma is in the blood, because normally those myeloma cells will be in the bone marrow, or indeed where the myeloma starts to grow in lumps or bumps outside of the bone marrow. And both of those can sometimes be classified as being more complicated to treat. We obviously then need to think about the myeloma's effect on the different organs. And then finally, we need to think about the genetics of the myeloma, so the actual complication within the myeloma cell itself. And we've had some discussion about that already. But when we're thinking about risk, we have to put all of these things together. And what some of the most recent studies have suggested is actually in some of the older, frailer patients, although all of this genetics we've been hearing about today is important, it's probably not as important as how well they are at walking or whether they need a wheelchair or whether they're bedbound. And that actually might be their most important risk factor that's going to determine how well their patient does. So back 20 years ago, this is what we all used to use, okay? And you can tell, importantly, it's 20 years ago because if you look at those survivals, they're way different to what we would tell any patient nowadays, okay? But we used to do it based on 2 simple blood tests, okay? And actually, we still do use those simple blood tests. But as I say, it's like, I'm going to say, it's not very sensitive and it's not very useful. And we'd have lots of patients who we think would do well and then didn't do well. So there's been lots of ways to refine this. And I think one of the important things about refining it really is from a doctor's perspective about how we talk to patients. Because again, if you're a newly diagnosed patient, or indeed a relapsed patient, and you're chatting with your doctor about what might happen, it's important to know what you're going to expect from that treatment, because that's going to alter as to whether you want to go ahead with that treatment. And so it's really important that we get this much better. And so just going back a little bit to what Professor Van Ness was saying earlier, he essentially talked about 3 different ways that the genetic code in the myeloma cell could change, and how that genetic code, if it changed, would result in the myeloma cells growing differently, moving to a different place and causing problems. And each of these different ways we've now discovered is important for determining the risk status of a patient. Okay, and he chatted a little bit about this, and our pointer, as he pointed out, isn't very good. But as I say, some of them about changes in copy number. And your doctor will measure this with either what we call a FISH test or a cytogenetics test, okay? In order to measure these, you actually have to have some myeloma in the bone marrow at the time. So it's usually done when a patient first presents or when they're relapsed. Okay, and there's a whole selection of different things that can happen. So you can gain a chromosome, or you can lose one, or you don't have to lose a whole one, you can just lose half of one. And as he said, chromosomes move around. So this is one where we've color-coded them, and you can see this one with chromosome 4. It's got a bit of a yellow chromosome stuck on it, which should actually be on the end of chromosome 1. And this one chromosome 9, which is painted white, has gained a bit of a blue chromosome, which should actually be stuck down here. So we can look at things like that. The other one, which is a new test which is out there, which requires a slightly different way of testing for, is what we call a mutation. And so that's just one spot in all of that coding that has changed. And it means that a protein goes completely crazy. Okay? Now that requires a very specific test to be done, which is sometimes called NGS, or next generation sequencing. Now that up to now has really only been available in many of the research labs. There's some tests which are beginning to come out now, which are FDA approved. It's a relatively new kid on the block. But as I say, one of the things about risk is that it's changed so much over time. When I first started doing myeloma 25 years ago, I was doing this test here, and at the time that was thought to be really modern and cool. As I say, now everybody's doing this test, which is this circus plot, and I could interpret this in the lab by just looking down the microscope, but as Dr. Van Ness says, now you need a couple of large computers and some really clever bioinformaticians to be able to interpret this. So we've learned an awful lot, but it also means that we've got lots more data, and much of the information we knew 20 years ago has now actually been shown not quite to be true. So we used to think that chromosome 13 was a bad sign, but now we've actually discovered that it's not chromosome 13 on its own, it's who it hangs around with and what else is going on in the cell that's actually the problem. And so it's these little final subtleties which are really important. So as I say, some things have kind of stood the test of time, and we've heard a little bit about this column here, the adverse features today. Okay, and the important thing, which Professor Holmberg also said, is that just if you have one of those does not mean that that's the end of the world. Okay, it's actually, you can kind of add them up. So if you get the full house, okay, it's not the kind of bingo you want to play, okay? But if you've just got one and you're fitting well, then actually we've all got patients that have lived for many, many years with myeloma. And so it's really important that we don't just look at one thing, that we look at the whole spectrum. And so that's why one of the complicated things about things that have gone on is that it's a real moving target. And so we've actually ended up with lots of different staging systems. And as I say, all of them are slightly different. So, for instance, this one I've got that's based on fish at the top there, I think we'll all agree who or which patients, unfortunately, are not going to do well. So those kind of 15% that we can predict that are not going to do well. But we'll have some discussion about the middle group, because some of those may actually do quite well. And this is a new finding, this one here, which is a new group of patients. We don't need to go into the details, but this is actually just a small, very small group of patients, about 6% of patients, with what we called double hit myeloma. And this is diagnosed using a combination of all of the new techniques. And you can imagine, if you're one of those patients, it's probably important for you and your doctor to know, for the very simple reason, unfortunately, for these 6% of newly diagnosed patients, their outlook is probably only about 18 months. Okay? And so when we're sitting chatting with patients and saying, oh, right, you know, you need a triplet therapy at the beginning, followed by a transplant, followed by this, and you can expect to see your children get married, your grandchildren go to college or whatever, then that's clearly not the right conversation to have with those patients that have this very poor outlook. And so what I would say about determining genetic risk is that it's not just the genetic risk, it's the whole package, okay? That it's changing day by day, and we're learning far more about it, about the little nuances of it. One factor doesn't mean you have high-risk disease. And it's best to chat with your myeloma expert to go into your risk factors, okay? Your local oncologist is fantastic, but we just had a big myeloma meeting in Boston 2 weeks ago, and the whole conversation of risk has actually changed a lot just after everybody presented their new data there. And so that has to have time to kind of move down in through the ranks, okay? So the question is, what does knowing your risk do? Okay, how does it help us? And I would say that for newly diagnosed patients, the main thing it helps us with is deciding what we can expect from treatment. Can we expect to have, you know, a 5-year period free from therapy, or are we expecting longer, or we expect less? Okay. I'm going to say, let's go back 5 years ago. We might think about, at that time, of changing our therapy a little bit depending on risk. But I think now the general feeling is, doesn't matter what risk you have, you should have the best treatment up front, and that you should be trying to get the best response. Okay? Doesn't matter on the risk of your disease. It's that old adage of put your best foot forward first. Okay? Or what we used to do, I don't know if it happens in the US, there's no point keeping your best china in the cupboard for special occasions. Let's get out and use it, okay? So don't keep your best treatments in the cupboard, let's use them all, okay? But patients with high-risk disease will often present clinically in a number of ways. The first one is that they may not respond to their initial therapy. And that always used to be considered high risk, and that was really when we only had 1 or 2 new treatments. Now we have a whole bunch of different treatments, and so that's maybe not considered such high risk anymore because we can just move to a different treatment. One of the other classic things of patients with high risk is when they have a great response to treatment and then, whoop, bounces back up again. You change their treatment, great response, oops, back up again, okay? And so when we're thinking about treating patients, we need to think about those kind of patients. So as I say, we need to put our best foot forward, do the best treatment we can. And so most of the time, that will be with 3 different drugs that work in slightly different ways. Although this week, the FDA have now approved the antibody daratumumab that we can use for newly diagnosed patients up front. So it might be that some patients now actually need to have 4 drugs up front, if they're well enough. Certainly we've already heard about transplants, and as Professor Holmberg said, it may be that patients with high-risk disease may actually need 2 of them. We need to think about always giving our high-risk patients a little bit of therapy so that their disease can't change its spots and come back. But we have to monitor those patients really closely because they're the ones where it can sneak back really quickly. And I think one of the things we don't know, and we're going to hear about that this afternoon, and I think all of the myeloma physicians are very excited about it, these new immune treatments we're hearing about, where rather than going after the myeloma cell itself, you go after the cells, the rest of the cells in the bone marrow migrant. Are they going to be good treatments for these high-risk patients? And then obviously, clinical trials. And if you do know that information, I'm going to give a plug to HealthTree here, which we're going to hear about later, putting that information in there so that we can compare patients who are on all of those new treatments and not have to wait 20 years to say, oh, this is high risk, we want to know about it now, then that's going to be really important. How am I doing for time, Greg?
You've got 5 minutes.
I've got 5 minutes. You talk quickly then. Okay. I'm going to miss this bit because otherwise I'm going to... So I want to talk about the last little bit. Okay. So a lot of what I've talked about at the moment is called prognostic. So that's when we see the patient at the beginning and we try and figure out what's going to happen to them. I want to move now to predictive. Okay. And that's where we try and give a treatment that's very specific for a patient. And so the idea is that we find what we call the target. So this could be a protein on the surface of a cell, or it could be an abnormality within the cell, which we know alters the way the cell grows. And then we design a test to identify that, and then we give a treatment to try and kill the cells off. And one of the, oops, that's not going to be much use, is it? Okay. Anyway, never mind. Underneath that lovely blue box, there is one of the things we found, okay, is that myeloma doesn't have one thing that makes it characteristic. It has lots of different things. But it's actually been quite cool because although we're considered a rare disease, many of the things that happen in myeloma patients, they may only happen in a few myeloma patients, but there's actually drugs from other cancers that we can beg, borrow and steal and use for myeloma patients. Okay, so I just want to give you a couple of examples of these. These are all ones that are in study and we're looking forward potentially to use them. So they're not available widely, but it kind of proves what we may be able to achieve over the coming years. So this is an example, okay? So this patient has what we call the V600E BRAF mutation. So that's a one very specific little spot. And the reason that that's interesting, it only happens in about 4% of myeloma patients. So in this room, I know there's maybe 4 patients that have got it, potentially, okay? But the reason why that's interesting is that it's very, very common in patients with melanoma skin cancer. Okay, and so this drug, vemurafenib, is a drug which is used for melanoma skin cancer. And so what we were able to do, this is a patient of mine when I was in London, and that kind of, the bright sunshiny spot was where their myeloma was, okay? And when the patient came in, they were really, really poorly. And we found out that they had this mutation, and we were able to get the melanoma drug for that patient. And 3 months later, having been on that drug, this is where the lesion was. And you can see it's not completely gone, but it's definitely shrunk, okay? And you can see that their light chains had come down dramatically. Maybe more importantly, the patient went from being bedbound to, when I knew something good was happening, he was sat downstairs in the cafeteria eating fish and chips. So I knew that he was responding to his treatment, okay? Unfortunately, it didn't last for a long time, but the actual principle is there. And this is another example. This is a different mutation, which is called N and KRAS, okay? And this one is often seen in lung cancer, okay? And so again, borrowed a drug from the lung cancer patients, and this is where their myeloma was, these bright spots, and you can see disappeared, okay? Again, didn't last a long time. So the question is, why doesn't it last a long time? And this is my kind of drawing as to why it doesn't last a long time. The reason is that these cells, when they grow, depending on where they are, they change their spots. So just because a cell in the shoulder doesn't necessarily grow the same way as a cell maybe in the hip bone. It changes its spots slightly differently. And so what we think is happening is that maybe the cells that were in the shoulder of my patient had that mutation and so responded well to the treatment, whereas those patients that the cells in the hip didn't have that mutation, so didn't respond. So we think of those as the branches, okay? And many of the treatments we've used from other cancers have maybe only been pruning the branches of the tree. And what we actually need to do is to go after this trunk portion. My pointer really doesn't work now. Go after the trunk portion and cut the trunk, okay? And there are some ways to do that, and this is quite an exciting new treatment. It's had a bit of a checkered history, which I can talk about over coffee later. But essentially, this drug was a drug that was used for chronic lymphocytic leukemia patients, okay, and was found to work really well for them. And so we were able to move it into myeloma, and we were able to go for this specific group of myeloma patients, which is called the 11-14 patients. And that's an abnormality that occurs early for patients, and so we can then actually use it for those patients. And what this drug seems to do is it seems to persuade those cells to die early. Only works in the 11-14 patients, though. I can see Greg itching at the side here, okay. I've got 2 slides, I promise. So one of the problems moving forward as we do this personalised treatment is how we do it, okay? And there's 2 different ways that the FDA have said that we can do it. The first way is to study all sorts of patients with the same abnormality. So like, say, take lung cancer patients, myeloma patients, skin cancer patients, and say, right, they've got this abnormality, we'll give them the drug. The other way of doing it is this way, whereas we take a group of myeloma patients and we say, right, okay, you've got abnormality A, you should have drug A. You've got abnormality B, you should have drug B. You've got abnormality C and D, we'll give you drug C first, and then we'll give you drug D afterwards, okay? And so that's where things are moving forward with now, and these are the kind of studies that are being designed. Last slide. All that I've said so far is about the myeloma cell itself, and we mustn't forget that that myeloma cell hangs around in the bone marrow, and that actually many of the things that are going on now is not because the myeloma cell itself is out of order. It's the rest of the cells in the bone marrow that aren't doing their job and aren't killing that myeloma cell. And so much of the work we're going to hear about later today is how to persuade those cells to kill the myeloma cell. So in closing, I want to say, just reiterate that everybody's myeloma is different, and the way we're going to get to the bottom of it is to learn more about the myeloma itself, but particularly about high-risk disease. We're learning all of these things because all of these different patients are being characterised, and we've got all of this new data, and HealthTree is going to help us on that. But it's important that as we move forward, we collect all of the data, but we don't forget those other cells in the bone marrow. So thank you very much. I'll finish there, and I believe you can have coffee now.